I have a few questions that I'll kick off the Q&A with, one per speaker, but I'm going to start with Darian. And Darian, if you could share with us some of Sutter's plans in workforce and also how Sutter deeply engages the community in your work.
I appreciate the question, Roseanne, and I imagine it's something very much focused, top of mind for all of our organizations. But fundamentally, as we think about the demand for care, as we think about the future, and there's about 11,000 people aging into Medicare every day today. And realistically, from a forecast standpoint, that's not anticipated to peak until early 2030s. And so with that in mind, ultimately, we need to make sure that we have the workforce in place to help support and care for our community and for our patients. And so when I think about, workforce, I think Rick, took us back to the early days of the pandemic. If we learned anything from navigating that experience together, it's that we have to compassionately care for the people who care for others. We have to care for our teams and reconnect them with their purpose and support. And so there's a number of different ways that we're tackling that from a workforce standpoint. One is continuing to expand pipelines, right? Pipeline development, helping to train the next generation. I'd mentioned and alluded to earlier, historically, we've had a presence in the graduate medical education residency space, but we're looking to quadruple the size of our physician graduates over the next 4 years, and really make sure that we're continuing to be a part of the solution in conjunction with a number of our partners throughout the region. In addition to that, one of the things we were talking about was cost of living, particularly here in our geography before we jumped on the panel, which is significant for our workforce. And so one of the things that we're continuing to emphasize is our role as an employer fundamentally has to be different in helping to address some of the burdens and socioeconomic impact that's having on our workforce. And so one example that we're tackling that here locally is actually we are one of two hospital-based schools of diagnostic imaging in the country. And we actually provide tuition-free education for folks looking to get into healthcare with a foundation level of education. And so they're leaving, with a degree that allows them to play a critical role with a license helping to support caring for the community without the burden of tuition. And we really think we need to think in scale that thought process and that methodology even further afield. And one of the things that, Rick had touched on, and I think, Rick, to a certain extent, I think all of us in healthcare are trying to be mindful of not having AI be the first conversation we have, but it's certainly top of mind in many of the rooms we walk into. But I do think as an enabler for our caregivers is really critical. And so one of the ways that we've actually launched that, we've partnered with a company called Abridge, who does provides ambient AI listening software that ultimately has, for thousands of our physicians across the peninsula and certainly in the South Bay, to reduce the administrative documentation burden. No one went into medical school to spend all their time, what we call pajama time at home, documenting in the chart what happened throughout the day. And I know our patients feel it, right? When you walk into a room and the doc trying to manage all the documentation can't, steer their eyes away from the computer. So we're freeing them from that in many respects. And what we've seen is about a 20% reduction in administrative documentation time for the physicians using this technology. And so how do we leverage technology to alleviate the repetition and the administrative burden from our clinicians and caregivers, really with a focus on connecting them with purpose, and ultimately it also helps us expand access. And so a multi-factor approach, particularly on the workforce front, connecting our teams with purpose and that purpose with progress, integrating technology, expanding the pipelines, and helping to alleviate the cost barrier, ultimately to become and serve their mission in healthcare. And as I think about, how do we connect with the community? We do that in a number of different ways. We're here in the community. I live down the street in Burlingame. At the end of the day, the walls to our hospital and our health system are non-existent in our mind. Right. And so we provide everything from, integrating volunteer, opportunities for our teams to providing free screening in a number of different sessions. We just hosted a men's and women's health free screening event in our community and our campus in San Mateo to help support the community. A number of our leaders sit on boards really trying to solicit information from the community and make sure that we're best serving And we also think one of the most important things is empowering our community with the information that they're interested in. And so, for example, this last year, we've hosted more than 6 community events here at the hospital and certainly in the community, focused on educating the community on really critical things that matter to them. What does it look like? Early signs of cognitive impairment, and what are your treatment options that should be considered, or what are the preventative options to our conversation around knowledge connecting to prevention, prevention connecting to wellness and well-being. And so there's a number of different ways that we're connecting with the community, and we're really excited to play that role. But one of the amazing things is many of our 2,000 plus caregivers and almost 1,000 physicians live here in the community and want to be a part of the solution. So we tackle it in a number of different ways.
Thank you so much, Darian. So Dr. Lim, I'm going to turn it over to you. And Kaiser has been innovative in solutions to work with their workforce, address kind of the high cost of living here and to retain a workforce. So can you share with us some of those creative solutions and also give us an action item to what policies you think that we all need to be thinking about to implement to make it better for all of your healthcare systems?
Yeah, sure. So, as we think about hiring, I really think about 2 buckets. One is recruitment, sort of recruiting the physicians and the staff. And then 2 is, of course, retention, right? So starting with what Kaiser Permanente does for recruitment is, number one, we provide above market wages and exceptional benefits. So these are material offerings. In addition to that, I think that we have to recruit for fit. And what I mean by fit is that, this is a very high cost of living area. So I'll give you an example of when we hire physicians, that we have to ensure that our physicians are either from the Bay Area, they grew up in the Bay Area, high school, family here. They have some anchor here that brings them back here. So maybe these physicians go to anywhere else in the country for their training, but then they want to come back because their families are here. So secondly, it turns out that having institutions like UCSF and Stanford in medical education is extremely helpful, because often, medical students and residents who spend time here, they end up meeting spouses who are in tech, and for that reason, they decide to settle here. So for us, that's been very beneficial to have those 2 academic anchors. For physicians specifically, we offer a home loan program where you can borrow up to 10% of the down payment of a home here, and then that interest is forgiven if you stay with us for over 10 years or more. And with regard to opportunities, we do have a Kaiser Permanente allied school, allied health school, and I think so we have programs for X-ray technicians and phlebotomists, but we certainly, as an opportunity, we can expand that. And as a medical center in Redwood City, we are expanding some of our externship programs, like in surgical tech, as well as physician assistants, and even hosting medical students from places like Boston University. And lastly, I'll just touch on a policy opportunity is, I think AI is a double-edged sword, right? So there are absolutely opportunities, and also there are threats. And I think we have to, as a healthcare ecosystem, I think we have to, say that AI is actually an opportunity, because it is going to help us with our work. The rates of burnout is quite high among physicians and nurses and staff. And I think we have to convince the next generation of healthcare workforce that AI is our friend, and that anything we can do in the community, especially when there's so much innovation in AI here, if you have a humanoid robot, for example, that can be your health buddy in the hospital, that we should be embracing that as a healthcare workforce and not as a threat for our job. So I think there's some policy and sort of some promotional opportunities available for all employers in the Bay Area.
Thank you very much, Dr. Lim. So I'm going to turn it to Dr. Pageler. Dr. Pageler, can you help us understand the challenges that you face with bridging the academic research with real world implementation in your field? Because you were able to explain it to us beautifully, but that kind of connection between the research and the implementation can be really hard to wrap our heads around. So I'd love you to dive a little deeper.
Yeah, thanks, Roseanne. There's two aspects of this that I think are important to touch on. One is that the technology is just advancing so quickly, and our researchers are focused on, on the next big technology and advancing that. And yet the applications and implementation into the health system involves so much in terms of designing the ideal workflows, and educating our staff and our clinicians, educating our patients and families, understanding how they may react or accept that. And that takes so much time and energy, and explicit energy, and explicit evaluation on the implementation aspects. So really pairing our incredible clinician scientists, data scientists with implementation scientists is critical to make sure that we close that loop and make sure that the technology is safely, meaningfully, equitably being translated into the clinical system. Similarly, there's a ton of data that's being generated in the health systems that we need to ensure that we capture and send back to our scientists, especially our data scientists, to analyze, so that we're creating this closed loop of a learning health system. So capturing all the information, learning from it, designing new systems, and then putting that back into the health system. I would say the second big point that I would make for research and applications of technology, especially in pediatrics, is that so much of the development and the primary research is done in the adult space, and there are significant questions about the applicability and the unique potential risks and potential benefits for children and families. And so, one example is the Apple Watch came out several years ago with its arrhythmia detection algorithm that was developed at Stanford, but all on adult patients and FDA approved for adult patients. But suddenly we had our teenagers or even younger kids showing up wearing their parents' Apple Watch. And what we were finding was that for some of our children with arrhythmias, our systems may not detect it because they weren't wearing it long enough, but they would go home with their parents' Apple Watch and come back in and say, "Hey, look what the watch caught." And so now we have researchers that are studying that and trying to understand, is that algorithm that was developed in adults, can it be applicable for the very different types of arrhythmias that we see in children and families? And that extends, those types of questions extend to every technology out there. So we're all excited about chatbots and how they may extend our healthcare services and extend the kind of personalization to our patients and families. And yet we're seeing some really scary things about chatbots with teenagers. And so how do we really evaluate that before we put that in to the systems for children and families? So lots of exciting work to be done and lots of exciting potential.
Thank you so much. I'm going to turn it over to Rick, and then I have a couple of questions in the chat. And I really appreciate, thank you, Joe Cafaro, for connecting with both our workforce board, which is NovaWorks, and our County Office of Education to talk about how we can really dive deeply into the workforce space. Rick, you're the Chief Operating Officer. So operational excellence is top of mind for you at probably pretty much 20 hours of a 24-hour day. How do you define it in a healthcare setting, and how do you measure it? Operational excellence.
Thanks for that. I could say I have a cheat sheet. It's like you can't see it. It's over on the right-hand side of my my bulletin board here. So at the end of the day, for us, it comes down to four things in terms of operational excellence. And at the end of the year, if we have met our targets and our focus areas and our outcomes in these four things, then it's been a good year. This is essentially what we're focused on. So the first one is, we talked a little bit about it, is quality, safety, and health equity. That's one of the core elements. And again, we can do all these amazing things and develop workforces and use AI correctly and otherwise. But if the quality is not where it needs to be as a result of that, then that's problematic for us. We measure quality in lots of different ways. It's a very complex equation. But as I mentioned before, one of the things that we do here at Stanford is we compare ourselves to some of the very best across the country to make sure that we've met the high standard that exists and exceeded it. And so that's one, quality, equality, safety, health, equity. The second one is patient experience. So again, we can be a great high quality organization and do really well in all of the other domains, but if the experience is terrible, then likely that's going to have implications on quality. It will also have implications on lots of other things. And so we have to make sure that our patients are having exceptional experience at the same time that we're delivering exceptional quality. And that's a never-ending journey. Healthcare is complex and challenging. People aren't here because they want to be. And so figuring out ways that we can enhance that experience productively and positively amidst what sometimes are the most challenging situations that people face in their entire lives is also an important part of what we focus on. The third thing that we focus on, we've talked a lot about today, is employee engagement and making sure that our teams are well supported and that they have the resources that they need to do the important work that they do every single day, and that we are, as an organization, responding to the things that they're telling us about their environment, about our patients, and making sure that they're in positions to actually influence the decisions that we're making. And so our employee engagement is the third pillar. And then last but not least is our financial strength. You know, it has to be there. We absolutely have to have it so that we can invest in all of the other things that we need to invest in to be able to deliver those outcomes. So when you look at those four things, that is how we define operational excellence. And one is not more important than the other. They are equally important. And if one is out of balance or out of whack, then the others typically are as well. And so that's something that we really focus on pretty explicitly as we operate what's about a $10 billion health system every day.
Thank you very much, Rick. So in our remaining 6 minutes, I'm going to turn it over to questions in the chat. First, I want to acknowledge and thank Lucy Wicks and Jen Tarai and Victoria Ramirez from Stanford. They put in the chat the link to Stanford Health in Redwood City and also the proposed new cancer center. I want to thank Stacy Wagner at Kaiser and Shasta Adesi and other Kaiser folks on this call for Stacy put in Kaiser's Academy for mental health scholars. So if any of you don't know Stacy, that's just wrong. So you need to connect with her because she's amazing. And the two questions in the chat, one is from Laura Palmer-Lowen at NAMI, is the question on mental health. How are your organizations addressing mental health care parity? How well prepared are your organizations to deliver the pending requirements for comprehensive care for the first incident of psychosis? So that's one question. And then second question for Kaiser and Stanford is, with decentralized outpatient care and telehealth, real estate portfolios. Many of you have large real estate portfolios, and I love this from DES, our architect and engineering firm, understanding the adaptation. So who wants to jump in on either of those questions?
I can jump in, Roseanne. I'll start with the behavioral health and then hand it over to my colleagues for the question oriented to them. So at Mills-Peninsula Medical Center here in Burlingame and San Mateo, we're one of the largest providers of acute adult and adolescent behavioral health in San Mateo County. And we've invested a number of different ways to actually expand existing access. And I'll talk a little bit about some of the exciting work we're trying to do, advocate for the state for some additional funding, because really appreciate the salient question around the necessity for parity in the behavioral health space. And so one, we have invested almost $4.5 million in the expansion of our and renovation of our psychiatric emergency services in our emergency department. We know fundamentally a traditional ED is not the ideal, suitable therapeutic environment for those experiencing crisis. And so behavioral health is really a continuum. And so that's one of the first steps, in that continuum. We also have outpatient services that we are expanding, intensive hospital-based outpatient services and partial hospitalization programs to help prevent, ultimately getting to the state of crisis. And then inevitably, we're also expanding and looking to optimize both thought and mood disorder infrastructure in our acute space. And so thought disorders are more like schizophrenia, mood disorders, anxiety, depression, acute capacity. And so we have multi-million-dollar investments going into expanding access to that care. And we're really excited because we put a proposal together through the state through what's known as BCHIP funding, or Proposition 1 funding, to actually expand the behavioral health infrastructure. There was over $1 billion allocated from the state, where we're advancing a project that's not only going to allow us to expand our acute behavioral health services with a particular eye on adolescent expansion, given the rapid sort of escalation of demand for our teens and early 20s, but also help us bring chemical dependency resources back to the community with a chemical dependency and rehabilitation hospital. And so we're really, really excited to advocate for those funds. So it's top of mind for us because certainly our community is going to need it now more than ever as we head into the next chapter.
Yeah, so I'll take the question around telehealth and the impact of that on real estate. So I think this is somewhere where, because of our value-based care and coverage model, that we provide omni-channel care, which means that it's whatever it takes to solve a patient's concern, right? Whether that's through a chat, an email, or video. And as such, so what we've done is say, if you have a problem and you want that solved, certainly, chat and virtual is an option. And because we're value-based, that we're able to provide those services without any fees or payments. And so that's slightly different from the fee-for-service model. At the same time, we recognize that a significant portion, right, of care delivery is still in person. It involves the human connection, human touch, maybe procedures. And as such, we continue to invest in facilities throughout Northern California. And Kaiser Permanente does have a large portfolio of real estate, both land and facilities across Northern California.
One additional comment around the real estate. The answer unequivocally is yes. We are absolutely looking at our real estate portfolio as a result, not only of telehealth and the shift and change in care models, but we've talked a lot about workforce today. The workforce is shifting and changing as well. And so we are assessing and evaluating our needs for various real estate assets on the basis of what's happening with the workforce. And so definitively, while a large real estate holder as Stanford is, we're looking at that every day and making big decisions every single day. So yeah, that's our answer.
I would just add, I mean, similarly for Stanford Children's and, especially again for pediatrics, where subspecialists are so few and far between. We have, our children's hospitals are very spread out, that the telehealth becomes an incredibly important way to reach children and families where they are and minimize the disruptions to school and the workday. And so that's dramatically kind of changed our approach to the physical space. And yet we still see that many of our children and families do want that direct connection. So it's really a balance that we're looking at.
I want to thank each of our speakers. It is with heartfelt gratitude that SAMCEDA is so proud that each and every one of you are longtime members of our organization, that you constantly support us in our public policy and advocacy work. We are here as your partner. We are here to continue bringing this type of information to all of our members that are on board today. I look around at this screen and I just feel incredibly grateful. While things may be somewhat chaotic in our world right now, and I feel that it's important to acknowledge that, we are so fortunate in San Mateo County and the Greater Peninsula to have people like our 4 speakers today who are willing to spend an hour of their time with all of us and all of you who give back regularly. I don't think we say thank you enough. So I am saying thank you. And this conversation could have gone on for many more hours. But again, on behalf of SAMCEDA, we are so grateful. Have a wonderful day.